I'm live. All right, here we go. So we titled this "1 Year as a RN Reflections." So as of today, I have been a nurse for 1 year. So I made it this far. So definitely enjoying myself. I just got off my shift. I'm a little tired. I look tired. Looking at myself in this live stream, I'm like, geez, I look really tired. It's okay. I feel great. I'm just a little tired. I'm gonna go to sleep after this, but just got done with a STEMI, and that was a blast. Went really well, thank God. And I thought I'd just come on here and talk to myself about myself because I love myself. I guess I don't know. Whatever. All right. So I have a the screen's shaking because I have a laptop, really crappy laptop, and it's just sitting on my lap, my couch, and I don't have anything, so I didn't think about anything to say while I was doing this, um, and I don't have anything, you know, actually planned, but I thought I'd just kind of talk about it. So first year as a nurse was really fun, man. I had a blast. I had a really good time. So far, it's been really great. Uh, so we did 6 months on a step down, cardiac step down unit, and then COVID hit, and I went to the cath lab, and now we did 6 months in the cath lab, and I am uh, very content with my choice. I really enjoy the cath lab. Love the cath lab. I just can't get enough of it. So I guess um, going from the floor to the cath lab as a newer nurse, a very new nurse, um, it makes me appreciate specialties, or I should say, like procedural units. I really enjoy procedures. They're really fun, especially something as big as a cardiac catheterization. Um, it's really just the I don't know, the autonomy you have. There's so much autonomy. It's crazy. You just start doing stuff. You just start doing stuff. This stuff just starts happening. So, like, we kind of run like in the cath lab. You run a custom code. You don't run a ACLS code in the cath lab. I mean, you can take parts of ACLS, but in ACLS, what's the end result? You go to PCI. So, oh, they're having a heart attack. Go to PCI, right? They coded. We got them back. They have ST elevation. Go to PCI. Well, what do you do once they're in PC? Once you're getting PCI, right? And for anyone who doesn't know what PCI means, percutaneous coronary intervention. That's PCI. So, so I'm like, so we ran the code. We got him to the cath lab. Okay, now what? Now we do other stuff, right? We do other stuff. Like, so I had a code we were running, and you know, you think so pulseless electrical activity, PEA. You think PEA, they don't have a pulse, right? Well, yeah, you don't have a pulse, but you can still have an aortic pressure. You can still have, like, at the root of the aorta, you can still have pressure, right? That doesn't mean necessarily that they're not. When we struck an art line down, we check a AO pressure. They have a pressure there. So yeah, they don't have a pressure at the wrist because it's like at the AO, it's like 60/40, right? So they don't have a good pressure, and they're technically quote unquote PEA. If you feel all their central pulses, if you feel a carotid pulse, you're not going to feel a carotid pulse because at the AO it's 60/40. but they have a pulse. You just can't feel it. They have a pressure, you just can't see it or feel it, right? And so you give an AMPA epi, all of a sudden that AO pressure goes from 60 over 40 to like 90 over 60, for maybe 4 minutes. And I mean, uh, you know, we're trying to get through. Like the end goal is to stent, stabilize, protect brain perfusion, right? Stent, stabilize, prevent brain perfusion. Hold on, what's my dog doing? Time out. Time out. Here we go. Here we go. Here we go. Here we go. I'm getting up. We're good. Everything's good. Okay, back to what I'm talking about. So yeah, I don't know. The code is, we're running the code in the cath lab, and it's not like the doctor's running the code, because the doctor is the interventional cardiologist, and he's working on the stenting, right? He's getting the access, and he's putting in the balloons. He's deciding the stent size. He's trying to diagnose where the blockage is, right? He's doing all this other stuff. He doesn't have the time or you can't focus on two things at once with something like this. So as the nurse, I'm running the code. So I get to run the code. I get to decide when we shock, if we're going to shock. I'm going to communicate with him. Hey, doc, V-fib. Or, hey, rhythm change, I see V-tac. And he's going to go, all right, back up. Everyone's going to take hands off. I'm going to shock, right? 200 joule shock, biphasic, whatever. So, the code is run basically by me. I'm pushing all the drugs, and I'm deciding what drugs to push. I'm interpreting the rhythm. All of it. It's really fun. I really enjoy it. And so, take that experience as a new nurse, and go back to a PCU floor. We aren't doing that at all. Even if they code, we're only doing the code for a few minutes before someone else comes and takes over. You know what I mean? Somebody codes, we do some compressions, we might get an AMPA epi, but the ER doc's going to come and innovate. You have the pulmonary critical care doc might come over and take over running the head of the code. You have a nurse who's going to start drugging. You got a nurse who's going to start recording. All of a sudden, you give report to whoever comes in, tell them what happened, and now you're kind of on the back burner. You're not doing it. And I don't think people realize that as much. New nurses come in to, like, say, even the ICU. Like, ICU might run the code a little more, but even then, you have a critical care doc. The critical care doc's going to be giving you orders. They're going to decide what the plan is, right? In the cath lab, the critical care doc, I hope he better come down and he better give me some, bounce some ideas. Okay, hey, have we given bicarb? What's a lactate? Can we get an ABG? Right? We can all talk about that stuff. Getting those, catching all your bases, making sure, do they need blood? Are their electrolytes okay? Checking all these things can be done by me, but it also, I'm pretty much, he might say, hey, give 2 amps of bicarb. Hey, cool, we're going to give 2 amps of bicarb. And then I'm going to go get 2 amps of bicarb and give my 2 amps of bicarb, and then I'm going to keep running the code. So there's a little input, but he may end up leaving, and it's back to me. So it's really, really fun. I really enjoy it. I have a blast every time I get into the cath lab. And so I have found that for me personally, that PCU is fun. Step down, whatever you want to call it. It's fun. It's all right, but it's not nearly as fun. I mean, if I'm gonna check a sugar in the cath lab, it's because it's gonna kill him if we don't fix the sugar. When you check a sugar on PCU, you're checking a sugar because it's ordered. and you have to give insulin to cover them for their food. And so it's just a lot of the same skills, but different reasons why you're doing it. And I think it was good to start off on PCU or start off on the floor for 6 months. Do 6 months on the floor. Get a feel for the other end of the cath lab. Where does the patient go, and where does the patient come from when they go to cath? If it's so, the patient can come from a bunch of different places, but one of the places is like a cardiac step down unit. They may be having chest pain. They aren't gonna die right in that minute. So they come, their throat may have bumped, but their EKG is fine. They stay overnight. They put on a drip or something, and in the morning we're gonna give them a cath. You know what I mean? And so we'll get report and take the patient down for a catheterization. And so being on that end for 6 months, kind of seeing the other side of the system and how it works, I think it was really good. It helped me. I think it definitely helped. But I am so happy where I'm at. I have every day. I just have a blast. So the other thing, I think I may have mentioned this in other videos, but maybe I haven't. But I will anyways. In the cath lab, sometimes they come with pads on them. So when someone's having a heart attack, you put pads on their chest, right? Put pads on their back, maybe, or on their side, right? Apical and lateral, left lateral, because that's where the sternal and apical, right? So the sternum is at the base of the heart, and the apex is left lateral at the side on your ribs. So that's kind of how your heart is facing. Your heart's kind of facing like this, right? It's kind of facing this way, right? And so you have one sticker on this side and one sticker on this side, and it kind of crosses back between it across the heart, right? So you want to get as much electricity across the heart as you can. But in the cath lab, if they don't have pads on and they're draped, how are you supposed to get the pads on while they're laying on their back and they're sedated or they're intubated? It's a little harder. So, and time is of the essence. If someone goes into V-fib, you got to be able to get them quickly. If they're not hooked up to pads, we use the manual clickers, right? So you hold them there and you charge it and you go beep, you get pretty clear, and then you put them on, right? You put the gel on them, gel it up, and then pop, pew, clear. Haven't gotten to do it yet. I want to do it. It sounds like fun. I'm kind of excited. So definitely want to try those paddles out. If we have to use them, and so that's another thing that's different in the cath lab. You have paddles. And you need to be the guy who catches it, right? So I'm watching the EKG to make sure we don't have like a reperfusion V-fib or something, or whatever it is. For whatever reason, they go into some kind of V-tach or V-fib, and they need a shock. I need to be able to recognize that immediately and gel up and get some paddles on the skin quick. So I really like that too. I think finding what suits you best, finding what fits your personality, and I think the speed and excitement of the cath lab fits what I like to do. PCU was all right, but I felt like I was just not pushing my limits on my knowledge base, and so I needed something that I'm gonna something that's gonna push me, and so make me better every day. Help me, ask more of me every day, which I really enjoy. So I'm off orientation, right? I'm off training. I'm on my own, which is a little crazy, but I really enjoy it. So, like today we had a STEMI. I medicated the whole STEMI on my own. I didn't have to do anything. I didn't need someone behind me, watching me. I did the whole thing and it was great. It went great. She got fixed. All better, right? But I guess, it's been a really good year. It's been a lot of fun. Um, and I don't know. After doing this job, I really don't know if I could ever go back to the floor. I just don't. It would be hard to go back to the floor after doing this job. This job is so much fun. My back doesn't hurt. My feet don't hurt. I'm not like dog tired after my shift. Um, Holidays off, weekends off. You get to work with a super super sharp crew. Not that there's good crews on floors, but I mean, you got to be pretty friggin' sharp. It helps if you're sharp in the cath lab, and we have some sharp people. Iron sharpens iron, right? So you got to have some good sharp iron in the cath lab, make everyone else sharper. So I love all the little gadgets, and I love all the autonomy. So those are some things I really enjoy. Um, one mantra of the cath lab, for me at least, was something I got from a ER nurse that told me when I was an ER tech, and he would say, slow is smooth, and smooth is fast. So if you're going slowly and smoothly, you're going to go quickly, and that's something really helps in the ER. Being smooth and slow and smooth, and making sure you're being continually smooth is fast. And so I really like that. I think that's a special ops. It's like some kind of military special ops saying or something. Um, but I've been using it because when you're under the gun in times of the essence, you want to operate, correctly, in the best way possible. So I like that. Um, and two other ones. One of the ER doctor or the interventional cardiologist told me. He's an older interventional cardiologist, just wise, very wise man, I think. And he said the two sayings he has for the cath lab. The first one is rather be lucky than good, and the other one is what is it? Perfect is the enemy of good enough, something like that. And so, perfection is the enemy of good enough, or something like that. Anyways, I guess these are just little things I've learned, I'm thinking about and seeing and getting experience with. So I am like super down for the cath lab. I freaking love it. It's so fun, and I like, honestly, like I try and find all kinds of like nursing people on YouTube, and I can't find any cath lab nurses. No cath lab nurses who do YouTube, uh, and so I'm like, all right. So it's hard to find. Hard. It'd be nice to find some seasoned cath lab nurses on YouTube, but I can't really find any that do videos, which is fine. But I'm gonna start doing them. I'm gonna do my little cath lab videos, I think, and I don't know if I could ever go back because the floor is the floor. There's just a lot of juggling, way more juggling, and like task oriented. Like you're juggling more, you're more task oriented, where you're just doing tasks. I have a bunch of crap I have to do. It just has to be done. You just have to get it done. Why? Because it does. And you're fielding phone calls, and at some hospitals they're tracking your every move with a little badge where they see how quickly you respond to your call lights, where they're timing you how quickly you respond to your call lights, or you have how many different ancillary staff are going to call you. I'm just going to list them. You got a CNA who's going to call you, right, with vitals. If the blood pressure is 140 over 90, you're going to get a phone call, right? Don't bother if that's their norm. You're going to get a phone call. RT is going to call you if they had to change their oxygen from 1 liter to 2 liters. You might get a phone call. PT, physical therapy, is going to call you if they were having trouble uh, standing up at the side of the bed, or if they did stand up for the first time at the side of the bed, they're going to call you probably. OT is going to call you if you know they need outpatient occupational therapy at home health. They're going to call you. Speech therapy is going to call you if they needed to schedule a barium swallow because they have a concern about their swallowing. The diet aid's going to call you if they're out of Pepsi and the patient ordered Pepsi and they're all out. They're going to call you. And there's so many more. So case management's going to call you. For if we need to get a taxi ride for a patient who's discharging, and you're going to have to call the house supervisor to get a taxi voucher to be able to make sure that patient gets a taxi. And you might get a phone call from a doctor because they're dealing with medically managing the patient, right? You might get a call from multiple doctors because there's multiple doctors on a case. I could really go on, but you are fielding a lot of. Oh, let's not forget the visitors, right, or the family members. You're going to take phone calls from family members too, and this is all these people I'm talking about times 4 or 5 because you got 5 patients. All 5 of them need all of this, right? So that's 5 times the number of phone calls I just talked about, right? And there's more. I could start even more actually, right? There's I'll stop. All right, we'll stop there. It's a lot of phone calls. You're gonna take a lot of phone calls every day, and you got 12 hours of it. So that's something I don't miss. Um, Charting too. You don't, as a cath lab nurse, you don't chart unless you're the monitor. If you're monitoring and then you're charting the entire procedure. But if you're the medicating nurse, if you're the circulating medicating nurse, you're not charting. You're giving all the drugs. Someone else is charting the drugs you give, and everything you do, someone else is going to chart. You say it out loud, someone else charts it. So that's pretty nice. Pretty nice. Uh, um, Oh, dude. Well, okay. So more people who would call you, like lab, will call you for all kinds of menial things. Pharmacy will call you for all kinds of menial things. Your nutritionist. We're talking like 10 people, 10 teams of people per patient may be calling you about something that may be important or may not be important, but they're going to call you. So, and that's on the floor. That's happening on the floor. And so I don't really miss that. I'm going to be honest. I don't miss that. I am not a secretary. Not a good secretary. Not a good secretary. So, you know, like fielding phone calls and taking messages and writing notes. Um, I could do it, but it's not something like I enjoy or like love to do. I don't do it here in my home. I don't write notes. I don't take phone calls. Somebody calls me, leave me a message. I'll get back to you. Text me maybe. I don't do that at home. I don't do it for fun. And I don't want to do it for my work. So I think that's one other reason that the cath lab really kind of fits my personality. I enjoy um, cardiogenic shock management or cardiogenic shock resuscitation. I love cardiogenic shock resuscitation. Absolutely love it. I also really like septic shock resuscitation. And we can get both. Sometimes we'll get acute on chronic or cardiogenic shock induced, like septic shock what is it? It would be sepsis, cardiogenic shock secondary to sepsis. So someone who became septic, and they went into decompensated heart failure, which really high mortality rate when you start combining stuff like that. Really high mortality rate. But I find it very mentally stimulating and enjoyable to do everything I can to help that person stay alive. So that's something I just can't get enough of. I love it so much. Um, and that's what I'm doing. And so I'm really glad that that's what I'm doing, because I just don't want to do anything else. So I think that's pretty much the main stuff I learned. That was a big one I learned. It was a big thing. So, and it's funny too, because when you work with like actively, patient who's actively trying to die on you, basically their hearts are dying on you, and you have to kind of bring them back to life and pull them out of the grave with the medications and the instruments and all the tools you have available to you, um, and you can do it staying calm, keeping a very sharp mental focus, and moving quickly but not in a hurry, right? And thinking 2 or 3 steps ahead, staying on top of all of this game you're playing, pretty much, anticipating what's going to be needed, and you know making correct actions that have positive outcomes. When you're able to do that in the cath lab, it just shifts your whole mindset when you go to the floor, because if you're not going to stress about somebody dying, right? If you're not going to lose your marbles because someone's dying and you're bringing them back to life, you shouldn't lose your marbles because a patient wants a Pepsi, and you shouldn't lose your marbles because the tray came late, and you shouldn't lose your marbles because you have a stat chest X-ray that has to be done, or you had to increase the oxygen from 1 liter to 2 or 3 liters, and notify the doctor about that, or get a breathing treatment. You don't lose your marbles over little things like that. That becomes a very little thing when you go, when you start getting perspective and a bit of a for me, when I'm getting a paradigm shift. I had a big paradigm shift. Um, and those things, not that they're not important, because if I'm in the floor, I'm in the hospital, and I want a Pepsi, you know what? You shouldn't drink Pepsi, actually. I take that back. Don't drink Pepsi. I don't drink Pepsi. How about ice water? If I wanted some ice water, like some ice water. I want some ice water, and I asked for some ice water. Hey, can I have some ice water? I'd hope that they would bring me some ice water. And I make an effort definitely to bring ice water everywhere I go, especially in the morning. If I'm running on the floor, I'm coming in for morning meds, I want to make sure there's a cup of water, whether there's ice or no ice, whether they want ice or not. I want to make sure they get the water they want. I want to make sure they have something to drink when I come in with their medications, right? So that is an important thing. That's not a little thing. And feeling comfortable is good, right? Not being hungry is not very fun, right? Um, but most people can go 30 or 40, 50 days without eating, and most people haven't gone a day without eating in 50 years, right? Most people don't go a day without eating. And you should, actually. You should go a day without eating. Could go multiple days. It's actually good for your body to go multiple days without eating. Just so you know, anybody out there, unless you have you know, type 1 diabetes, or thyroid disorder, or certain things, you're on chemotherapy. Yeah, maybe, I don't know, might not be as great, but if you're in a normal physiologic state, it's good for your body to go hungry and be hungry for a few days. It's actually okay for it every quarter of the year. So I don't know what I'm getting at. The point is, being hungry is not being hungry. To me, being hungry is, it's okay to be hungry. Like right now, I'm hungry. So, so I don't know what I'm getting at with this. I don't know. I guess I'm just rambling. I'm a little tired. I gotta think. Yeah. So it's been good though. I'm really enjoying my and like I love the call. Oh my gosh, being on call is so fun. I don't know if I'll ever get tired of being on call. Maybe I will one day, but I really love being on call. I love getting a call in the middle of the night, and I gotta rush over to the hospital, and like it's going down. So I love that. I think it's just very fulfilling. It's to me, it fulfills a need, of purpose. You wanna. Every human needs purpose. If you don't have purpose, you're hopeless. You're hopeless, and you're purposeless. You got nothing to live for, man. You got nothing to live for. So I find life enjoyment and life satisfaction out of being called in the middle of the night to help somebody who's dying. I like it, and then you get to go home. That's another great thing. Like let's say we brought this patient back to life. We take him up to the floor. We go home, go back to bed. I just find that amusing. So these are my thoughts. These are my thoughts. If I went back to the floor, I'd have to be doing something good. I'd have to be doing like CVICU probably. I'd probably go to CV like if I was ever gonna go back to the floor, I'd want to go to like one of the best CVICUs in the nation. Like I'd want to go to St. Vincent's up in Portland, Oregon. If Portland doesn't get so crazy, Portland's crazy, man. If Portland one day calms down and it's not like nuts, maybe I'm not gonna move up to Portland now. I don't know. I don't go to Portland. It's too expensive, but the point is, if I was gonna go back to the floor, I probably want to go to like a big, academic teaching center or a CTICU, cardiothoracic ICU, something like that. Because after doing this, I could never go back. I don't think I could go back to PCU. I mean, not never. If I had to, I would. But I wouldn't be finding it nearly as much. I would not be smiling nearly as much. I'm always smiling. I just have this big smile on my face all the time. I'm just so happy, and I just love my job so much. Because of, I guess, because of the people I work with, the job we're doing, the knowledge base it's required, the skills that are required. All of it. I just love it all. It's just so fun. It's really, really fun. So, I guess that's all I'm going to say. Just really enjoying myself. Definitely enjoying myself. It's getting late, and I have work tomorrow. So, I'm going to call it. This is all I got. Have a good night, everyone. Anyone who saw this. That's it.